Prior to approximately 10 years ago, medical education really didn't incorporate end-of-life care in our formal training. When we started expanding at Hospice Palm Beach County and doing inpatient units, our census grew from around 135 to 200 patients, where we currently have over 1,200 patients a day that we take care of. A movement within hospices and within palliative care, within hospital-based palliative care units as well as universities, really started developing palliative care programs in hospice and end-of-life care, developing education and curriculum that's been mandated by several states and medical societies.
The fellowship program is pretty unique because it exposes you to all aspects of hospice care. Hospice care is not just about working on a unit, it's also about doing home visits and about doing assisted living facility visits and nursing home visits. Talking with families, that's a huge component of what I do. It's seeing any new patients that arrive on the floor while I'm working, doing my day-to-day rounds. Afternoons are more variable. Sometimes I deal with ongoing family issues, deal with new patients.
After the year 2012, in order to become board certified, the only way you'll be granted privileges in that specialty is to have a fellowship. The fellowship program that we're offering is a one-year clinical fellowship which will allow the individual, once they're done with their training, to be a well-rounded physician that will be able to provide consultative services, primary care and end-of-life care, and symptom management.
The reason for doing a year-long fellowship is because this is different to any other type of medicine that we're trained in. Residency is very good at getting you sharp on your physical examinations and use of medications and getting used to stress and getting used to sleep deprivation and all those other things that residency instills into you. It does not train you how to deal with all the emotional aspects of medicine. That is primarily what hospice is about. It can be very emotionally evocative because there is a great deal of stress towards the end of life and a great deal of ethics to navigate your way through, as well as getting very comfortable with administering pain medication, getting very comfortable with physical symptoms at end of life, and getting very comfortable with dealing with patient-orientated goals as opposed to telling patients what you think they need. This is where we actually ask patients and find out what they think they need and see if we can provide that. I think it's benefited me a lot in my ability to explain things and my ability to accept that sometimes they're not going to think the same way I do and I still have to abide by their wishes.